Hi, and welcome to another pharmacology tutoring video. My name is Kiana Rush. I'm a tutor for Southwest College of Naturopathic Medicine in Tempe, Arizona. And today we're going to be talking about drugs for angina. All right, so to start it out, we're just going to talk a little bit about the mechanism of the disease itself. What is angina? So angina is pain in the chest, and it's caused by hypoperfusion of the heart muscle. So hypoperfusion, what does that mean? It means that the blood's not getting to the heart muscle itself. So essentially the heart tissue is starving, and because of that, it causes a pain response. So these coronary arteries that you can see in this picture, you'll actually not be able to get blood going through those. And because of that, the heart muscle actually starves and is causing real pain. All right, angina can be controlled through two different mechanisms. And both of those mechanisms have a little bit of overlap, but also a little bit of specificity. So vasodilation is the first mechanism that can treat angina. So we're making these arteries bigger by vasodilating. And because we're increasing their size, more blood can get to that heart tissue. So nitroglycerin. So if you remember physiology, how nitroglycerin increases the diameter of the vasculature. So we'll just abbreviate nitroglycerin as NG. NG is going to increase nitric oxide. You're going to get a lot of cyclic GMP inside the cell, and that's going to cause smooth muscle relaxation. And that's how the vasculature is going to dilate and help angina with nitroglycerin. And with a CCB, or calcium channel blocker, we'll just call it a CCB for short. You'll see it like that all the time. These also cause vasodilation. They block calcium from entering the myocyte or the heart cell, right? This causes less action potential. So there's really no signal for it to fire or contract or to even work because no calcium is getting in. So you're going to have less contraction of muscle, including the heart and vascular smooth muscle. So these CCBs are doing two things. Not only is the heart muscle itself beating a lot less hard, it's also vasodilating. So those CCBs are where that overlap comes in between the two mechanisms to treat angina. All right, and as you see below, moving on to cardiac depression, CCBs are also cardiac depressants. That's our second mechanism of treating angina. So the first was vasodilation. The second is cardiac depression. CCBs do both, vasodilation and cardiac depression. So now let's talk about beta blockers because we already covered CCBs. Beta blockers are purely cardiac depressant. All right, so a beta blocker, how does that work? So we have beta receptors in our heart, right? So we have beta 1 in our heart. So when we block beta 1, which is what we're attempting to do here, we're creating an antagonistic response, right? So we're blocking a signal to that beta receptor. So beta 1 is blocked, and less sympathetic signal is received. And why is this useful in angina? Because if we're blocking that sympathetic response, we're going to get less fight or flight signal. The heart is going to beat less hard and hopefully cause less pain for the patient. All right, quick review before the drugs. We have vasodilation and we have cardiac depression. Nitroglycerin induces vasodilation. Beta blockers induce cardiac depression, as were calcium channel blockers, vasodilate and cause cardiac depression. All right, to start talking about the drugs, the first drug that vasodilates, nitroglycerin. We talked about the mechanism of action. It's used in acute angina. One thing that really separates nitroglycerin from other drugs is the fact that it works really rapidly. Within a minute, it can be used sublingually, as a patch, which is also called transdermal, or as a capsule. I also found in my studies while preparing this video that nitroglycerin can be used as a suppository rectally to treat anal fissures, which was very interesting to me. I think it might reduce bleeding. Not really sure on that, but kind of interesting. Second use for that drug. Some side effects are orthostatic hypotension and headache. I really want to talk about headache here. Why would headache be a side effect with nitroglycerin? Remember that we're vasodilating with these drugs. So when we vasodilate, even the vasculature going to the head, we're going to get this huge rush of blood going to the brain and possibly cause a headache. Great. So amylodipine, this is our first calcium channel blocker that we're going to talk about. I have a slight mnemonic to separate this calcium channel blocker from the rest. So as you see, amylodipine has more effects on the vasculature than the heart. So I remember that amylodipine has low heart effects. That's my mnemonic for separating it from other CCBs. Side effects are pretibial edema, flushing, and dizziness. I bet that dizziness has to do with the fact that CCBs cause vasodilation and possibly aren't allowing that blood to fully come back to the heart because the vasculature in the lower body is going to be dilated. So maybe they're just not doing as well returning blood. That causes dizziness. Also hypotension, so related to the dizziness. Okay, Varapamil. Varapamil is a little bit different as far as CCBs. So my mnemonic to remember the differences in Varapamil, I remember that it's very effective on the heart. As where amlodipine has low effects on the heart, but a lot on the vasculature. Varapamil has a lot of effects on the heart. It's very effective on the heart and minimal effects on the vasculature. So a side effect of Varapamil is constipation. And why do you think we would get constipation with a CCB? Well, if we're blocking calcium from entering the muscle, right, and it won't contract, the smooth muscle in the GI is also not going to contract. And we're going to get reduced peristalsis and reduced stooling, so the patient will get constipation. All right, moving along here. Diltiazem, the last CCB we're going to talk about for vasodilation. Very useful in similar things as other CCBs. I would remember that diltiazem and Varapamil can both be used in AV node arrhythmias. That kind of sets them apart a little bit. And that's because these have more heart effects. Amlodipine isn't really used in AV nodal arrhythmias quite as often because it has more vascular effects. All right, talking about cardiac depressant drugs. These are drugs that kind of tune down the amount of work the heart is doing. Sorry if you just heard my cat. She's hungry. She's always hungry. The first drug we're going to talk about is a beta blocker. It's called Propanol. Propanol is a very good drug to become familiar with. It's very high yield, and you'll just keep seeing it again and again. So beta blockers. Propanol is kind of I don't want to call it the original, but it's non-selective. So it's blocking beta 1 in the heart, and it's also blocking beta 2. We're going to see some issues when it starts blocking beta 2 with its non-selectivity. It's not very good that it does that. So some issues with blocking beta 2. Beta 1 is good. We're cool with blocking beta 1. It's going to slow down the heart, give us all those nice effects to reduce the pain in our chest. But when we block beta 2, we find beta 2 in the lungs. So that can cause bronchospasm. And this can be fatal in asthmatic patients. So don't give your asthmatic patient propanolol. Not a good idea. Metaprolol, this is a little bit more selective than propanolol, so we're working away from some of those side effects that could possibly happen with a non-selective beta blocker. So this is useful in diabetes, asthma, contraindicated in diabetes, asthma, and chronic kidney disease. Almost all of these drugs are, except for atenolol. It has a little bit of a difference with asthma, and we'll talk about that. Well, let's talk about why beta blockers are contraindicated in diabetes, asthma, and chronic kidney disease. Well, we talked about asthma, right? Beta 2 causing bronchospasm. So beta 2 can cause bronchospasm. So non-selective beta blocker is not good. So we've already established that. But what about all of these contraindications for angina drugs? So diabetes, why would it be contraindicated in diabetes? So in diabetes mellitus, it'll actually cause delayed response to hypoglycemia. In asthma, like we said, beta 2, bronchospasm, not good. And in chronic kidney disease, CKD, you'll often see it abbreviated as, beta blockers are going to lower the blood pressure, right? And they're going to lower the amount the heart is working. Why would that be really dangerous in a kidney disease patient? So the kidneys are going to get hypoperfused and possibly atrophy even more than they already are. That's what happens in kidney disease. Generally, the kidneys become fibrotic and atrophy. And hypoperfusion, if we lower the blood pressure, will be even more dangerous in that situation. Atenolol has one important difference that's good to know. Atenolol is not contraindicated in asthma. Ooh, that's good. It spares the lungs because it's beta 1 selective. So that's good. So a little mnemonic to remember 2 drugs here. Asthma, we use albuterol, and we can use atenolol. All those A's. So I kind of group those together, just a little memory mnemonic for myself. Great, so we're finished with the drugs that I would like to review for angina, but let's do a few review questions just to make sure we're hitting the main points here. What type of beta receptor is found in the heart? Beta 1 or beta 2? Beta 1. That's why it's bad if we have a non-selective beta blocker. It'll block beta 2 and affect the lungs in an adverse way. Why is propanolol dangerous in an asthmatic patient? Like we said, beta 2 becomes blocked and causes bronchospasm. And that can kind of be a double whammy for those asthmatic patients who are already suffering from decreased airway space. Why is atenolol more safe in asthmatics? Well, it's beta 1 selective. So it's not affecting that beta 2 and not causing that double whammy. Which CCB has the greatest effect on the vasculature and the least on the heart? Amylodipine, right? Amylodipine low effects on the heart. Which group of drugs have constipation as a side effect? CCBs, right? Because we're reducing the amount that smooth muscle can contract, and we're going to increase transit time because we're decreasing peristalsis. And lastly, why is headache a side effect of nitroglycerin? Vasodilation is not specific, right? So it's going to vasodilate most of the vasculature in the body, including going to the brain. And that can cause a headache. So if you guys have any questions, or if you would like access to these notes, feel free to send me an email. We'll make sure we get them to you. My email is located right here. And I just encourage you to keep taking really detailed but well-organized notes. Highlight where you can, simplify where you can, and make it fun. Pharmacology is a great opportunity to review multiple subjects, including physiology and biochemistry. So let me know if you need any help, and happy studying.